Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. Macu Health with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit OIEBroadcasting.com and sign up today.
Welcome back to part 2 of my interview with Dr. Shechtman and Diaz. In this episode, the doctors discuss the newest treatments for diabetic retinal disease. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Dr. Shechtman, you mentioned before about peripheral hemorrhages. Now, if we examine a patient and they're totally normal, and the only thing they have is peripheral hemorrhages, what does that mean to you, especially if maybe the person has a little bit of a belly and they look kind of like they may get diabetic, that diabetic look, or maybe they're just thin, they look fine, but they have peripheral hemorrhages. What does that mean to you?
I'm definitely concerned with peripheral hemorrhage. There's no question about it. We have decreased capillaries out in the periphery. Peripheral hemorrhages is known to be a progression towards worsening of diabetes if they have a diabetic retinopathy or the progress into diabetic retinopathy. You're looking at an area that's more susceptible to capillary dropout. So those hemorrhages may actually get worsened and even develop, it changes into a more severe stage and has been even associated with PDR. So I never really ignore peripheral hemorrhage as a whole. Dr. Diaz, would you agree?
No, that's absolutely right. And remember, it's only not diabetes, ocular ischemic syndrome. There's other conditions that basically can cause peripheral hemorrhages. And to me, there's got to be an explanation for it. If there isn't, then we got to dig a little deeper.
So if you see that, you'll send them out for different labs to have them checked out.
Depends, right? Is it unilateral? Is it bilateral? But yes, it definitely starts to get me going in terms of, is this related to the diabetes or is this something else?
So let's get into that. If it is unilateral, what are you thinking? And what if it's bilateral, what are you thinking?
Well, unilateral, first thing that would come to mind, especially on the periphery, I'd look at their IOP and see if it was low. I mean, I'd be thinking about ocular ischemic syndrome. I'd be more concerned about evaluating the carotids, for example. Bilaterally, peripheral lesions, I mean, if they're known diabetic, then I probably attribute it to that, but also hypertensive changes can lead to it. I probably just monitor them closely.
So Dr. Diaz, with OCT now, OCT angiography, tell us about the role that fluorescein angiography has. Is its role diminishing or is it still as important as it always has been?
I think for me, a wide field FA is about the most useful thing you can have in a diabetic, right? Because it basically allows you to catch them early, right? You can see the foci of NV out in the periphery before it starts to cause problems. So personally, I don't think it's going away. But not everyone has access to wide field fluorescein angiography, and the technology is expensive and so forth. So it's about what you can do with it, and also how early you can start using it in patients. I think that at least the baseline FA is important for every patient, and at least maybe once or twice a year, just to monitor those areas of capillary dropout, see if there's small foci of NV that might be forming, and then that might allow me to start treatment a little earlier, for example, than I would otherwise. I think classically you think, okay, heme, then proliferative diabetic retinopathy, but the capillary dropout percentage might also play a big role here. And for me personally, allowed me to start treatment and at least start talking to them about it sooner, so that if I need to, it's not out of the blue, right? And I can show them the images and show them the progression, for example. So I don't think FA is going anywhere, but I do think wide field FA in diabetics is the optimum modality.
100%.
And gonioscopy, we see hemorrhages. When are you doing gonioscopy to see if there's angle neo? We have to look at the iris very carefully. At what point are you doing gonioscopy on these patients?
I think for me personally is if I'm seeing sort of an asymmetry in IOP from one eye to the other, for example, if there is evidence of severe non-proliferative diabetic retinopathy, and I just want to be sure that we're not sort of tipping into that neovascular area. But I would say for me, IOP is a big driver. It takes a lot for me to pull the gonio prism out. But I would say IOP asymmetry, a risk of glaucoma, stuff like that. That's what I'm reading.
And Dr. Shechtman, you're more primary care in a way. Are you pulling it out a little bit sooner?
I do actually do it as standard for my more severe non-proliferative diabetic cases. Anything that I question to be neo of the iris, I definitely do it. But I do think that the IOP is a major driver. I've actually even had some patients who didn't really have much neo of any in the iris, and it swooped right into the angle. And Dr. Diaz and I just share what I like to consider to be a train wreck of a patient with neovascular glaucoma. And those are the ones you want to avoid, because I mean, no matter what he does in trying to inject that patient, which he did and did PRP, we had to send it to our glaucoma surgeon to be able to end up with a tube. And they don't end up with a good prognosis no matter what. So if we can try to avoid it, if we can try to find that neo as early as possible and then treat it appropriately, that's the best way prognosis for the patient.
So let's talk about proliferative diabetic retinopathy. Dr. Shechtman, if you could explain it again, and then we'll have Dr. Diaz talk about the treatment.
Sure. But before that, I just want to add one thing, because we are talking to the optometric community in many cases, and we're talking to patients, is that even though Dr. Diaz may not be treating a lot of his senior NPDR patients and may be watching it, there are other retinal specialists that might. So I think as ODs, we need to be referring these patients no matter what. These are not patients that should be in our office followed up every 4 months as we did before. And I think Dr. Diaz may pull the trigger on different stages. Say somebody, Dr. Diaz, who has a patient with PDR in one eye, or who, like you mentioned, you mentioned a relationship, and this is a type of patient is not compliant. He's not going to come back to you. You may potentially pull the trigger on that. So I think as ODs, we have to be referring that patient regardless of the treatment and or not, because we have various doctors doing different things. So I just kind of wanted to address that. From the PDR point of view, proliferative diabetic retinopathy is a multitude of different things. We're looking at hypoxia, we're looking at oxidative stress, we're looking at inflammatory perspective, and we're looking at VEGF. VEGF to me, as you mentioned, and I think you alluded to this very well, was we need to have a homeostasis of it. The reason why we use anti-VEGF is to be able to have things and let the body start healing itself. We know that VEGF increases perfusion to the anti-VEGF, increases perfusion to the body. Patients do better with the medication because you're giving time for the body to heal itself. Problem with these medications is that they have a short half-life, and you've got to keep injecting the patient once a month or once every 2 months. But the driving factors towards proliferative disease in these new, fragile, immature vasculature is VEGF, is these vascular endothelial growth factors, in addition to inflammation, which is why we have used steroids in the past as well to treat the disease, particularly DME, and of course, hypoxia being the driving factor for VEGF to start forming.
Dr. Diaz, what are the clinical signs that you're seeing when someone with proliferative or even the pre-proliferative that you may pull the trigger on? Start with pre-proliferative. I know we talked a little bit about it before, but with the pre-proliferative and that the signs, the clinical signs, and then into the proliferative, just because it gets confusing for the audience, and we do have people that are from the public that are watching.
Yeah, when you're at a stage where you're sort of deciding between severe NPDR versus early proliferative diabetic retinopathy, I'm always looking at the disc. I'm looking to see if there's any sort of neovascularization of the disc, albeit if it's very small, a small foci. Also, how much percentage of the disc is being taken up. You want to look for ERMA. You want to look for neovascularization in the posterior pole. You want to look for foci of NV out in the periphery, right? You want to monitor the size of that NV, how many foci there might be and where they're located as well. Of course, it goes without saying, if you see any sort of pre-retinal hemorrhages, then you're already at that sort of high-risk PDR stage, and treatment should be started as soon as possible. But for me, if I see a patient with a severe NPDR, I am already talking to them about potentially starting treatment. If they've missed a few appointments, if they are themselves don't show quite a good understanding about their condition, I may start treatment right away with PRP or so forth, before we get to that stage, right? It's about kind of trying to understand at what point they're at and what the trajectory might be. But yes, for sure, I'm looking at the disc to look for any NV because that's highest risk, and then out in the periphery, make sure you see any foci of neovascularization that might cause a problem in the future. And of course, if you're seeing fibrovascular proliferation, then you're more, you're higher risk at that point.
So you mentioned laser treatment with PRP. Explain why you would use laser treatment and what it does and how does it help the patient and how much time does it actually buy you?
Yeah, so I mean, it's pretty amazing. Actually, we're destroying retinal tissue to sort of try and decrease that hypoxic drive, right? It's usually the peripheral areas of the retina that are not receiving blood flow, and we know that the VEGF is sort of highest at that border between perfused and non-perfused. So by basically lasering the peripheral retina, you're cutting down on that hypoxic drive. You're trying to decrease VEGF load in the eye, which then over time is going to cause a regression of the neovascularization, right? So basically, you're just trying to upend that balance and switch it back into the non-hypoxic state. It's the start of something serious. I like to do it when I see patients that may be having trouble with follow-up, patients who've missed several appointments before. It is a more permanent treatment. I think PRP is absolutely crucial in the management of diabetic retinopathy. I think that some people can be managed only with, but you need to be very sure that patients are coming back. If they've missed an appointment, they might only get 2 strikes with me, not even 3. If they miss 1 or 2, just to help prevent any problems in the future.
So, and how about combination therapy, PRP? Oh, we're getting some feedback. I'm not sure where that's coming from. Do you hear that feedback?
I do hear it. Not sure where it's coming from.
Diane, I think it might be from you. If we use combination therapy, PRP and anti-VEGF, how often are you using both with these very severe patients? And does that seem to be the best mode of treatment?
It really depends. If they are actively bleeding and they are in the active proliferative diabetic retinopathy stage, I like to talk to them about combination therapy. We know, the medication is going to work right away. And the laser does take several weeks for the scarring to form, for the hypoxic drive to go down. It's not immediate, right? So if they have vitreous hemorrhage, then I'm more likely to start with injections and then talk to them about PRP, whether or not I can do it at the same visit or shortly thereafter. If the view improves, for example, and I can actually see the peripheral retina for treatment, then I do like to do a combination therapy. Some patients, I think it's a few rare patients that may say they don't want laser. I think for the most part, they understand. I tell them it's a chance for us to not need as many injections in the future if this were to happen again. And I think they kind of get on board at that point because, like you mentioned, injections are not that fun. But I think combination therapy is perfect for the patient who has active vitreous hemorrhage, pre-retinal bleeding, and where you need to get that VEGF drive down as soon as possible. If the other eye, for example, is not in the proliferative stage, but it might be in the severe stage, I'll talk to them about starting laser treatment in that eye, without the need for injections, to hopefully not need any injections in that eye as well. So it works both ways, but it all depends on when I'm seeing them at what point.
And is cryo used anymore?
I personally have not seen that in all of my training. I think that it's a very inflammogenic treatment. I think that there might be very, very niche roles where maybe you don't have a view out to the periphery and you need to try and just kill that peripheral retina. But once again, I think this is nowadays with the advent of small incision surgery, I think it's no longer really as indicated.
And if the patient has rubeosis, which are those dangerous blood vessels that are not regular blood vessels that could bleed very early, what kind of treatment would you use at that point when you see rubeosis?
Well, one thing, I think it would depend, right? Are they in active neovascular glaucoma stage? Is their IOP up? If that's the case, then I would do anti-VEGF and also start PRP treatment as soon as possible. If it's just some small vessels that I'm seeing and I'm worried that they're in the proliferative stage at this point, then I think starting PRP and monitoring them over time for regression of these vessels is very reasonable as well. It all depends on how fast and how urgent things might be.
Let's switch to macular edema. Dr. Shechtman, if you could go over the new nomenclature of macular edema, and why is it changed? Why are we calling it something different than we did, say, 10 years ago?
So based on the EDTRS, we used to call it clinical significant macular edema. That we had the treatment for laser, which was focal laser, and these were patients who didn't have central involved areas, and they were 20/40 or worse. Following RISE, VIVID, and VISTA, and the approval of anti-VEGF, we started calling diabetic macular edema. Specifically, we either have center involved or non-center involved macular edema. Center involved macular edema is the center 500 microns, typically having some sort of thickness around 300 microns or more within that center. And believe it or not, these patients can actually be 20/20 to 20/25 visual acuity, which later on goes to discuss as to should we be treating these patients or not with good visual acuity. The non-center involved is right outside the 500 area of micron in that central circle of the OCT. And the question becomes with those, should we be treating those? Is laser an option in those patients, or can we monitor?
So just for the people at home to understand, you could have macular edema, but not have proliferative diabetic retinopathy. If you could make the distinction between the two.
Sure. Proliferative diabetic stage is a staging of the diabetes. We talked about the non-proliferative, which are the stagings without any neovascularization or signs of neo, as Dr. Diaz had very eloquently stated, the fibrosis, the vitreous hemorrhage, and so on. The non-proliferative stage is all the stages that we discussed, where we talked about hemorrhages and exudates and Calmol spot. Having any kind of fluid in the central part of your vision, that macula, that real estate, perfect real estate, that becomes diabetic macular edema. Now, there is chances of increasing with more worsening of stage, but we've seen DME in patients with mild or moderate NPDR, and we've seen no DME in patients with proliferative disease.
So Dr. Diaz, this is, I don't know if there's a correct answer for this, but you're the one that has to make the decision. So I see a patient, they have diabetes, and we do an OCT, and they have a big area of macular edema, but the vision is still 20/20 or 20/25. Do you treat these people, or do you not treat them? And if you do, what kind of treatment?
Yeah, that's a great question, and one that I answer almost on a daily basis. And if the patient has 20/25 or better vision, I tend to observe these patients, especially if I'm seeing them for the first time. They were referred in with diabetic macular edema, and as far as they know, they have zero complaints. You ask them, they're like, "My vision's fine. I don't know why I'm here." And I start the conversation with them where I'm like, if you have inflammation, you have swelling of the retinal layers, and this over time may cause vision to go down. And we know from the protocol V data that outcomes were about the same at 2 years, whether or not they were treated with injections, laser, or just observation. So I think I like to tell the patients this is a sort of a wake-up call. If we can control, work on our sugars, work on the diabetes, and maybe that we won't need injections in the future. We won't need treatment. And I bring them back in 6 to 8 weeks and just follow them again. I think it's important to have these patients seen by a retina specialist because that conversation needs to be started. And I don't like having to see a patient and first visit being like laser PRP, we need to work on this quickly. I want to, try and at least modify their disease a little bit by encouraging understanding and maybe a shift in lifestyle and so forth. So I tend to observe, but if the other eye has gone downhill, maybe I'll treat a little sooner, and I'll talk to them and saying that I'm worried that things are not getting better and so forth.
Macu Health, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
So if you see that big area of edema, that big blister on the OCT, do you ever see that go away?
It can definitely go away. And I think that, whether it's the better diabetic control, whether it's related to just flux, and how much you're leaking that day, for example, I think that is variable. And also having more data points helps. I'll bring them back, take another photo, look at the OCT again, and kind of see which way they're going. If it's getting worse, but their vision is still fine, then I might be pushing a little bit more to, like, maybe we should start treatment here, because I'm worried that the next time I see you, it's gonna be even worse and your vision will be affected.
And let's talk about the different treatments for macular edema. So let's start off with laser. Is grid laser still used anymore? And how does laser help macular edema, or is it not really, is more of a third line treatment at this point?
Yeah, well, I think that the use of focal laser for diabetic macular edema has gone down over the last few decades. I think with the availability of anti-VEGF agents and how effective they are. I mean, you have to remember we're causing focal scars in the macula, which, if depending on where we're lasering, there's a risk for, it involving the fovea over time with RPE creep and so forth. You have to be very careful. So I would say there is a role for it. If you see that focal microaneurysm and you see that circinate ring of exudates, and you know that the leaking is coming from that specific aneurysm and it's sufficiently far away from the fovea, then I think doing focal laser might obviate the need for numerous injections down the line. And I think that's sort of the most beautiful case scenario for focal laser. But oftentimes that's not the case, and it's sort of diffuse leakage. You don't know where it's coming from. The FA can be, if you manage to get an FA and it's not so clear, then doing grid laser, and potentially wiping out some of their vision, causing a scotoma, then I think that's where things might get a little more tough. And I think that's where the role of anti-VEGF and steroids has really taken off.
So if we look at the anti-VEGF treatment, we have Avastin, we have Eylea, we have Lucentis. Does it matter which one you use?
I think that we have a bit of data that shows that in patients who present with initially worse visual acuity, maybe 20/50 or worse, that aflibercept was shown to have a higher gain in vision. I think this is from the Protocol T data. So I'm a fan of Eylea in patients who present with poor vision. Otherwise, Avastin is a great medication and oftentimes a first line for me. And I see patients oftentimes respond very well to that. So you do have, I think by having choices, it makes it better because you can tailor it more personalized to the patient and to the current specific condition. But Avastin is fantastic, and so is Lucentis.
If you could explain how the anti-VEGF treatment actually works by getting rid of the macular edema, how does that happen?
Well, it's all about modulating the cytokine profile in the eye, and by decreasing the pro-inflammatory mediators in the eye. And over time, just causing a reconstitution of the small blood vessels that might have been damaged from the ischemic damage from diabetes. So, we know that the VEGF levels, stay in the eye for about 4 weeks or so. And we do see a peak response after about maybe 2 weeks or so with each of the agents. So, it's all targeted sort of at the basement membrane and just reconstituting the integrity of the blood vessels. And each of the different types of treatments, for example, we know Avastin is a full antibody. We know that Lucentis is a monoclonal humanized antibody fragment, and Eylea is sort of a recombinant fusion protein. So they all have different sizes. They all have potentially theoretically different levels of penetration into the retinal tissues, which can also impact a little bit of their effectiveness. But it's just about getting into the eye to try and decrease the amount of vascular permeability.
And the side effect profile, we talk about the possibility at the beginning for systemic, but as far as ocular side effects, do you ever see much side effects from these medications?
Thankfully, no. I mean, we know that, the scariest one being the risk of endophthalmitis or an infection from the injection itself. I think what I tell the patients that they're most commonly going to see is probably subconjunctival hemorrhage. They might notice some increased floaters from the medication, for example. And then I warn them about the signs and symptoms of endophthalmitis. But for the most part, it seems to be pretty well tolerated and thankfully effective as well.
And how about steroids, Ozurdex, and in the future, I11. If you could talk about that.
Yeah, steroids work very well. We know that it's not just VEGF here. that is causing the problem. We know there's numerous other inflammatory cytokines that are not being targeted or dealt with anti-VEGF specific injections with Avastin, Lucentis, or Eylea, for example. And steroids do very well in managing all the other potential cytokines that are involved. And I oftentimes, it's not my first line treatment because of the associated risks with using steroids, IOP rise, cataract formation, and so forth. But in patients who are deemed not responders to VEGF therapy, I don't hesitate to get them started on it because it can work and it can be pretty dramatic in a lot of these patients. And it's, thankfully the Ozurdex implant lasts for about maybe 3 months or so in the eye. Uluvian is touted to last up to 36 months in duration. You do have elevated cataract formation rates. You have to talk about this with the patients. And of course, the risk of needing incisional glaucoma surgery down the line is also something that should be discussed. But it's helpful to have these tools in our toolbox to deal with patients who are not responding as well as we would hope.
And Uluvian, is it available yet, or it's not?
Yes, Uluvian is available.
And is it something that you've used as of yet?
Personally for diabetics, I have not used it. I've used Ozurdex, and usually that's been enough. And patients, I've had it last for up to 4 or 5 months in the eye sometimes, depending on the patient. So I have not found the need yet to jump into Uluvian, but I'm sure there's a patient out there that could probably benefit from it.
I can tell you from my old surgeons, they did use Uluvian just once or twice on a patient. Problem is, it's almost 100% cataracts, no matter what, for sure. And the increased intraocular pressure in those, maybe even needing surgery, is much higher. With Ozurdex, it's actually relatively safe with the patients. And most of the time, if they do develop intraocular pressure rise, it can be treated with anti-glaucoma medication, especially because it's short lasting.
And what percentage would you say develop elevated intraocular pressure?
Say maybe there could be a chance of as high as 1/3 from the studies, but from the ones that I've seen, and my old surgeon used to do quite a few of them, I didn't really see it that bad. And I believe that you can do pretty much a test to see if the patient will be susceptible. So a patient can be put on a steroid for about a month, and just a topical steroid, to see if they're susceptible for increase in intraocular pressure. What about you, Dr. Diaz?
Yeah, I oftentimes I like using Durazole as a test.
Yeah.
And I'll know pretty quickly whether or not this patient is a higher risk. And if I know they're an IOP responder, then I might shy away from using it.
And would you say it correlates pretty well with Durazole, the pressure going up?
I think so. Durazole has pretty good penetration into the eye, and I think that if you don't have a pressure increase or pressure response to Durazole, I think that I feel pretty good that something like an Uluvian, which is a very low, much lower dose and over a longer period of time, that I think you'll probably be fine.
Now, this is a tough question because everybody's different, but if a patient is diabetic, they have no eye changes, how often do you recommend they're seen in the eye doctor's office? Dr. Shechtman, I'll start with you.
I still say once a year. Definitely, they're a high-risk patient who can develop changes. And I have seen patients that within a year develop into more moderate or even severe stage within a very short period of time. So I say a year for sure.
And Dr. Diaz, if they have a little bit of diabetic, maybe a couple hemorrhages, how often do you think the optometrists, the people that are referring to you, would you recommend that they see these patients? Because typically you're not going to see these people. You're going to see them when the wheels are coming off the bus.
Right. Yeah. If they're in a mild or even a moderate, you're talking every 6 months, 6 to 9 months or so. Once again, depending on the patient and sort of how fast this has been happening for them, right? If you can tell that this, you have a fundus photo from a year ago and there was nothing there, and all of a sudden you have exudates and hemorrhages, then I would watch them a lot more closely.
And how about diabetics, Dr. Shechtman, and LASIK? What kind of advice do you give your diabetics who want to get LASIK?
There's been some controversies out there because we know diabetes affects we always talk about diabetic retinopathy, but we forget that diabetes affects the entire eye. We can get cataracts early onset from diabetes. You can get a decreased wound healing, dry eyes, intraocular mobility problems, optic neuropathies. So we kind of forget about the cornea, which is very susceptible, particularly with all those nerves. Can the patient get LASIK? I say yes, but there are patients who probably may be more at risk for any issues with wound healing and or more than anything, dry dry eyes. I think it's an impact, but I don't think it's a contraindication from ever getting LASIK.
Dr. Diaz, what do you think about that?
Yeah, I think the patient just has to understand here. I think that if they're trying to get glasses independence or super high myop here, and it's just for quality of life, I think that it's an individualized decision. If on the other hand they've had issues with diabetic retinopathy and had treatment and so forth, and I'd be very wary to probably recommend it. Just by understanding that even the fact of having LASIK, and let's say you have some fibrovascular proliferation in the back, I mean, the pressure goes up to 120 sometimes during some of these procedures, and you might have complications even related to that. So it's individualized, and I think as long as they understand that there might be further problems down the road, I think that's okay. But you're just trying to educate them.
And Dr. Shechtman, contact lenses and diabetics.
You do know I'd never fit a contact lens. I think Dr. Diaz is more likely to fit one than I did to get an abrasion. But I think it's the same thing. Intolerance, dry eyes, those kinds of perspectives. We have increased thickening of the cornea. So in and of itself, it make them more susceptible to more intolerance. But again, I don't think it's a contraindication, but contact lens group by any means.
Dr. Shechtman, one question before I get to my last question. Patients with posterior vitreous attachment that are seeing that big floater, the retina is okay, and they always want something to get rid of the floater. Do you have any tricks?
I tell them they have to be friends with these lovely floaters. No, but I don't have tricks, but actually Dr. Diaz does have a couple of tricks up his sleeve. There is YAG vitrolysis and there is fluorectomy. One of my surgeons actually used to do quite a fair amount of fluorectomies, which is nothing more than a vitrectomy. But the problem here is you're putting the patient, a 20/20 eye, at a high risk of developing a retinal detachment. And some of them did develop complications. The key thing about this is when it is effective, it's incredibly effective, but you have to identify the right patient. So before you recommend sending a patient over for a fluorectomy, I usually give them a little bit of what I call a cool off time. I have a floater myself, and at the beginning, it drove me absolutely nutty. But after a while, it's like a bad boyfriend, and you get used to them. You get used to that friend of yours, and it kind of settles down, and you don't see them as much every so often you visit. But if our people who are very affected by it, there are wonderful questionnaires that one can really determine. You do an ultrasound and an OCT en face to look at them objectively. And if it's been about 2 or 3 months, and I know doctors in the area who may be practicing on fluorectomy, Dr. Diaz, I would recommend it to them to maybe potentially consider doing it. There are some patients who are very detrimental by them.
Dr. Diaz?
Yeah, it's actually an up and coming topic now in the retina community. I wouldn't be surprised if we start to see more and more of these over the next 5-10 years or so. But once again, it comes down to patient selection, right? We know that there's an element of neuroadaptation with floaters. I tell patients, give me 9 months. I'll bring you back. If this is really a life-altering experience for you, then we can consider maybe doing surgery. But I don't rush into it, right? I mean, the retina surgery is very, very delicate, and although outcomes are pretty good, there's always a risk of something going on. And in a patient with the 20/20 eye, otherwise, it's just something that I wouldn't want to see. So I developed a relationship. I talk to them. I tell them that let's see if anything happens. Let's see how you look in 6-9 months, and then continue talking to them. Oftentimes, most of the times, they got smaller. They forgot about it. They'll still occasionally see it, and everything's fine.
What is the laser treatment that they do for it? How effective is it? And is it like shooting fish in a barrel?
Yeah, to be honest, I don't have a lot of experience with it. I haven't really seen it myself, but it's a YAG laser, which is a photodisruptive laser, and you're sort of blasting whatever vitreous fields you can see. I have a distinct memory of a video that I think was presented at a retina conference where the YAG laser was focused too far posteriorly, and they caused a suprachoroidal hemorrhage from inadvertent damage from the laser. So it's certainly higher risk. I mean, you're not really getting rid of the floaters, right? You're making them smaller, presumably. So it's not really a definitive treatment in my eyes.
Like they did to my kidney stones. So my last question, and you guys have been great, and this is terrific. And I want to ask you, what recommendations do you have to prevent people out there, if they just started getting diabetes, maybe to reverse it or help them from preventing getting diabetes? So Dr. Diaz, we'll start with you, and Dr. Shechtman, you could chime in at the end.
I personally, I think that's all about relationships. I think that if you are recently diagnosed with diabetes, you have to make sure that you are developing a partnership with your provider, right? Whether that's your primary care provider and your other ancillary providers, you need to be comfortable. You need to make sure you have a trusting relationship with them, because this is a lifelong condition. If you do not get along with them, or you feel like there's some disconnect there, find someone else, because this is not something you want to wait on. If you're not yet diabetic and you want to try and prevent it, I mean, it's all about lifestyle modifications, right? Get moving. We know that insulin resistance is a big key. We know that weight loss is important here. We got to reanalyze our dietary habits, and so forth. And just being aware of it. I mean, this is something that we're going to be dealing with a lot in the next coming decades. And, you want to try and do as much as you can to prevent it.
Dr. Shechtman?
I think you had alluded to a lot of this, and it's so true. I usually like to quote Benjamin Franklin when he said, once an ounce of prevention is worth a pound of cure. If we stop the diabetes from ever starting, we stop the pre-diabetic from becoming diabetic, we stop the insulin resistant from becoming pre-diabetic, we're stopping the disease. Once the disease starts, it's going to go a course of progression. So I talk to patients and I counsel them about standing up more, moving more. I don't need them to go join a gym, but taking a couple of steps. We all have these our phones, our iPhones, kind of almost challenging yourself to take up more steps. Trying to eat more frequency, smaller meals, I think are really important. Try not to skip breakfast. I think breakfast is incredibly crucial for diabetics. It's all about your insulin, and your insulin has to be moving and taking care of the right amount of food. Fasting is not the best unless you're doing some sort of fast from 5 a.m. to 5 p.m., but you really want to start eating more frequently. And of course, trying to make those lifestyle changes. But I also tell them, be realistic. If you want to have a little piece of cake at a party, you enjoy it, but you don't have to have the whole entire cake. And then you also try to make better choices throughout. And I think by educating them with photos, and they can actually see some of these changes, and when they come back, they see lesson of this, they reward themselves. I think that's really important too. And I think that helps them motivate them to become part of their own management plan. It's much easier to retain the vision that you have to regain it later with Dr. Diaz's injections.
So I want to thank Dr. Diaz and Dr. Shechtman for joining me today. Dr. Shechtman is a wonderful educator. I've seen her speak many, many times. She's a tremendous speaker. Dr. Diaz, you have such a wonderful way about you. You have a very conservative approach, and I think patients really like that. So if people want to find out more about you, Dr. Diaz, and they want to visit you as a patient, how could they do that?
So, I'm currently seeing patients pretty much all across the South Florida area. So I'm currently with the Eye Centers of South Florida. I'm in the process of opening my own practice down south in Miami. So that should be up and going pretty soon. But quick Google, and I think you'll run across me.
Dr. Shechtman, how can we find you?
I have the great pleasure of working with Dr. Diaz, Dr. Hoffman, and various other doctors at Eye Centers of South Florida, both at North Miami Beach and Fort Lauderdale. But if anyone has any questions, I'm always happy to talk and discuss, and I can relate them to Dr. Diaz. So you can email me at dianashe@comcast.net, and I'm always happy to continue educating. We're here to serve our patients and to work together.
Well, I want to thank you for joining me today. You guys have been amazing. This is Dr. Kerry Gelb for Open Your Eyes.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. Macu Health with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We're certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe for You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe for You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe for You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe for You.
And most importantly, the reason why I buy Safe for You is because it's safe for me and you.